In this video, I will discuss 5 tips to reduce your risk of a C-section. Coming up. Hey everyone, Dr. Wes Davis coming to you today. I make weekly videos with tips and tricks to provide you with the best available evidence-based information to give you the best possible outcome for you and your baby. So if you're new here, please consider subscribing. Okay, so no one wants to have a C-section if they don't have to. So today we're going to discuss 5 tips to reduce that risk. Tip number 1. Gaining too much weight has been shown to increase the risk of C-section by up to 60%. Whenever possible, you want to gain the amount of weight as recommended by the Institute of Medicine. And these are BMI, body mass index based recommendations. So I'm going to put a chart up here that shows you what the typical recommendations are for underweight, average weight, overweight, and obese. And you can see that the more towards the overweight and obese you are, the less weight is recommended for total pregnancy weight gain. Tip number 2, induction of labor in a first-time mom might increase the risk of C-section. If you do have to be induced, then I just say, well, it'd be nice if you have what we call a favorable cervix. And I'll put a little graphic up here that talks about the Bishop score. It kind of explains that. But if you have a Bishop score of around 10, then you can be pretty well assured of successful labor induction. Now, sometimes it just has to be done, and that's okay if there's a clear medical indication. Induced labor, especially in a first-time mom, may take longer than spontaneous labor. Don't let it feel like, oh, it's been so many hours, nothing's happened. That's normal, and we're going to talk about that in a minute, a little bit more detail. New information will be coming out later this year on induction of labor in first-time moms. It's called the ARRIVE trial. The study has been completed, but the results have not yet been published. So we don't really know from that study whether or not induction of labor in first-time moms increases or decreases C-section rate or has any other good or bad outcomes as a result. So I recommend stay tuned. When that comes out, I will definitely be discussing it in a future video. Tip number 3, give it plenty of time. Doctors thought normal labor was for a first-time mom versus a mom who's had babies before completely different than what we've been taught for years and years. There was this thing that they talked about called the Friedman curve. Is from like the 1950s or something like that. Super old, really hadn't been validated in a modern population. A couple things that have changed over the years, one of which is the use of epidurals is much more common now. Overall, people are having babies at older age. The Friedman curve does not really apply anymore. We really need to understand what normal labor progress is in this era of medicine. This idea of a failed induction. So they tried to induce me, nothing ever happened, so I had to have a C-section. This really should be a very unusual situation. It is currently defined as 24 hours of no cervical change. The water's been broken and you're on Pitocin having contractions every 3 minutes for 24 hours. If there's no cervical change, that's now defined as a failed induction. And I can tell you that that is extraordinarily rare. Much more likely would be either that the mom's condition or the baby's condition deteriorated. The other thing we talk about is failure to progress. And you need to think of those in the first stage of labor and the second stage of labor. Now, the first stage of labor, really you have to break down into latent phase labor and active phase labor. Basically, we're talking about active labor here. So that's now defined as being at least 6 centimeters. So arrest of dilatation, first stage arrest, is now defined as 4 hours of no cervical change beyond 6 centimeters. If you have what's called an intrauterine pressure catheter that shows adequate contractions, or 6 hours if you either don't have the pressure catheter or the contractions are not adequate for whatever reason. So really we're talking no change for 4 to 6 hours once you've gotten to at least 6 centimeters. Those don't happen a whole lot. Now they still happen. Either a big baby, baby's position isn't right, or baby's not tolerating labor again, something like that. This is whether you're being induced or whether this is spontaneous labor, that really you're not in active labor until 6 centimeters. And anything less than that, these numbers don't apply. And I have let people be in latent phase labor for up to 24 hours. You will on occasion have a little bit higher risk of either fever in labor or infection, but that's not an indication for a C-section. We can treat the infection with antibiotics. Babies can be treated after delivery with antibiotics. Arrest in the second stage is when you've become completely dilated, and now we're talking about no descent of the fetal head over a certain period of time. So, and that is broken down by whether it's your first baby or not your first baby. So first babies, so that's called nulliparous, you've never had a baby. 4 hours of no descent or rotation of the fetal head if you have an epidural, and 3 hours if you don't have an epidural. And then if you're a multiparous patient, so you've had babies before, then the numbers are 3 hours or more if you have an epidural and 2 hours if you don't. When you start using those kind of criteria, you're going to call C-section a lot less frequently for a failure to descend or second stage arrest. Tip number 4, if your baby's breech at 36 to 37 weeks, consider external cephalic version. That's where we rotate the baby from breech to try to get the head to come around. That could reduce your risk of C-section by up to 40%. So it works about half the time, but of course not every single person that has a successful version will ultimately have a vaginal delivery. Baby's breech, talk to your doctor about possible external cephalic version. Tip number 5, consider operative vaginal delivery over C-section when it's appropriate. When used appropriately, following the guidelines, they are considered a safe and effective way to reduce your risk of C-section. One issue can be that some newly trained physicians might not be as comfortable doing operative vaginal deliveries. The number of cases that residents are doing in training now is a lot less than, say, when old gray-haired guys like me trained back in the day. So we had a lot of experience with operative vaginal deliveries, feel very comfortable using forceps and vacuum, but some people might not. So that's an important one to talk to your doctor about even in the beginning. If you're trying to do everything you can to reduce your risk of a C-section, then you want to know, well, how comfortable are you? What's your experience with operative vaginal delivery? Because that is an option in the appropriate situation. It is safe and effective and could reduce your risk of a C-section. Another thing to mention, people ask frequently, is does an epidural increase the risk of C-section? And the answer is no, it doesn't. There's never been a study that showed an increased risk of C-section from an epidural. It can take a little longer to push a baby out if you have an epidural than if you don't, but that's okay as long as you're aware of that. And the last thing to tell you is that heart rate monitoring is very important. It is the standard of care to monitor moms in labor. Continuous monitoring might actually increase the risk of C-section and not provide any additional benefit over intermittent monitoring. Now, that's mostly talking about spontaneous labor. We have to monitor moms continuously if you're being induced or if you have other complications, preeclampsia, bleeding, things like that, because the fetal heart rate tracing will often show us that there's a problem before it becomes a big problem. But if we're talking about just plain old spontaneous labor, everything's going fine, then intermittent monitoring is perfectly fine. It is considered equally effective as continuous, and it might actually reduce the risk of C-section because sometimes you see things on the monitor that they're transient, they don't mean anything, and they kind of start a chain of events of interventions that could ultimately lead to a C-section, when if you just let things be, they would have been fine. If you are being induced or having other complications, or you're on Pitocin, then the main thing that really could reduce your risk of C-section is being sure you're delivering in a facility that has nurses that are accredited to provide electronic fetal monitoring. And what it basically does is provides a framework for interpretation of the fetal heart rate tracing. It provides a standardized way to categorize the findings that are seen, and that allows for clear communication between the nurses and the doctors, and it also leads to more standardized interventions based on what is being seen. That could also reduce your risk of C-section. I hope these tips help reduce your risk of a C-section in the future. If you have questions, please feel free to put them in the comments below. And thanks for watching, and have a great day.